something.
I'm sorry? We're going to get started. You are at the Safety Net, Buncombe County Safety Net meeting today. We have basically a one-item agenda, which is we're going to get some updates on current efforts that are happening in our county around infant and maternal safety and health, and efforts to prevent and reduce mortality in those areas. So we have guests today. I'd like to start with introductions. And I am Jan Shepard. I'm the Public Health Director and Division Director for Health and Human Services. And I am a co-chair with Jim Holland and Dr. Mullendor of the Safety Net Committee.
I'm Lynn Muller, I'm the Medical Director for Buncombe County. I'm Beth, Nurse Practitioner at HCCM.
I'm Jackie Geiger with Case Legal Services.
Joey Urchek, Family Preservation Services.
Stacey Candido, Bishop.
Sarah Penny, Bishop.
Annie Carpenter with Community Care.
Cindy Wood, Community Care, the OB team lead.
Julie Levitt, I'm the OB Program Manager for Community Services.
And Todd Valenius, Medical Director at WNC Community Health Services.
Scott Plucker, Winchester Minnie Jones Health Center.
Melinda Ramage, Project Care at Mayheck OB.
Maggie Adams, Manager of Community Center Health Home at Mayheck.
Dan Frame, Medical Director of the Mayheck Family Health Centers.
Evan Richardson, Director of Quality Improvement and Patient Safety at Mayheck.
Molly Cleveland, Nurse with Nurse and Partnership.
Leslie McCrory, Consultant with VIA around perinatal substance issues.
Amy Schitt, Social Work Division Director at Technical.
Robin Ward, Executive Director of Mayheck.
Zoe Bosher, Community Health Assessment Coordinator for Buncombe County. Karen Schwartz, Western Carolina Medical Society.
Ana Graça for the Access Western Carolina Medical Society Foundation.
Thank you all for being here. So without further ado, I will bring our guests to the forefront. From Mayheck, we have a whole team today. Dr. Melinda Ramage, and Maggie Adams, Evan Richardson, and Bill Frank. So you'll please join us on stage.
Great. Thanks for having us here. I'm just going to give a quick introduction, and then Evan Richardson is going to give our talk and have some time for discussion. So many of you have heard me talk about preconception health. I came about a year ago to this group talking about trying to get and engage our community around a multi-sector wave and momentum to really focus around women's health as it relates to the future generation of community health through preconception health. And so what we've been able to accomplish together as a team is that momentum continues. And in our organization of Mayheck alone, there are so many different initiatives and projects that are happening, both in the Family Health Division and the OBGYN Division and our Regional Services Division, that sometimes the right hand doesn't always know what the left hand is doing. And in the current environment where we are actually moving more towards a perspective of population health, you know, as a clinician, we've always been focused on the patient in front of me, maybe the panel of patients that I care for. As we are now part of an ACO, we're moving more towards a value-based method of looking at healthcare, changing the way we deliver healthcare. This continues to give us opportunities to do things differently. So within Mayheck, we've actually started to create a population health team, not just looking at our patients, but how the community that our patients live in affects the health of our patients. And so with that perspective, we've seen a new opportunity to partner with the county, with the community health improvement specialists and that contract to actually drive improvement, not just for our patients, but for the entire county, using our patients as a foundation of what that might look like. And so that's what we're going to talk about today, is that approach. And so you've already heard our team here, and these are representatives of the work that we're doing that partner with many of you. We have Melinda Ramage, who has been working with the substance use and addiction in pregnancy. We have Maggie Adams, who has been working with the community-centered health home, getting into the communities, creating support for doulas that live in the communities, and then actually figuring out how do we actually engage community health workers within the clinical setting of Mayheck itself. And then we have Evan Richardson, who is by trade a nurse midwife, has been a practice manager, so has been in the setting of clinical care on both sides, and now is leading our quality improvement efforts and population health team. And so I'm gonna let her take the stage and really talk about what our vision is, and really focusing on creating a data dashboard that gets at the key drivers of both infant and maternal mortality and the projects that we're working on.
So it's very exciting to be here today. This is my first time with the Safety Net Coalition, and I hope you should come back. I have been in position for the last year helping MAPEX put together a population health infrastructure and strategy. And we're really excited to share with you today our vision, in part to engage you in a conversation, get input from you, but also to engage in a conversation about how we can actually think about collaboration at a greater level that helps us all get the results that I think we know we all desire. Our current population health vision begins with inherently our desire to do a better job for patients that MAPEX serves. Of course, having learned over the last few years that it's not just about, and I think in reference to caring for the people that are right in front of us, and that we cannot do it alone. We can't do it just as healthcare providers without other individuals and agencies in the wider community, and we can't just focus on people inside the walls of our clinic. And so the vision that we have takes that into account. And we know that everyone here in this room understands that really we can't, none of us can do it alone, that we need each other to achieve the results that we're looking for. So we are at a place where we're beginning to come across as a whole organization. So we have a shared vision across all of our clinical areas. And fundamentally, we are striving together to have an impact on healthy women, families, and communities. So that's our big driving goal of what we're trying to achieve. We're doing that through focusing on eliminating black-white disparity in infant mortality, black-white disparity in diabetes mortality, and we'll talk to you a little bit about the coherent model that we're using that would let us know why all of this is connected. Really, how can we make sure that mom-baby dyads are preserved for communities, and then eliminating the opioid addiction. So we actually have work groups and teams that are focusing in on these three bubbles. We know that beyond diabetes, there's multiple complex condition care, but we're starting there. Our approach draws from best practice, so what has been shown in other communities to work, and also what have we learned from not only what we've done, but what others in the community are doing. And so we have activity happening in each of these areas. For instance, we have an embedded lawyer from Vista Legal who's helping us with some of the social determinants of health, point of care. We have embedded case managers from Community Care of Western North Carolina. We're in the process of developing our own care management program. We partner with many of the home visit programs, et cetera. We certainly are doing our best to make sure that as a clinic, we're delivering evidence-based care. We're looking at how can we sustain this, both from a fee-for-service, but also changing payment models. And then the work, particularly the work in community-centered health home, is helping us learn about how do you actually engage communities and build agency and strengthen communities. But today we want to focus more on what do we measure, and what will help us drive improvement, and what happens when we're actually able to share data and have that data be actionable, drive changes. So this is our model that, this is kind of our bigger model for how do we achieve healthy women, families, and communities. And this actually is about to be published, I believe. Dan, is that correct, coming out? It's been adapted. So this is, it comes from, can you reference that for me, Dan, to share the reference?
Yeah, so Michael Liu, who is the director of the Maternal Health Bureau, came out with this in 2003 as the life course model and theory, which has then really been driven and improved upon. And this is a book that is coming out on life course theory that enhances around preconception health to help explain the differences that we see between black-white outcomes.
And so if you'll see here, infant mortality is what we have going on in our community is that we have a gap that begins at birth or in the first year of life. So in terms of African Americans and whites, there is this gap that starts at birth, And then these colored lines represent a combination of risk factors and protective factors that make a difference on overall life potential in individuals and communities. And no surprise that if we start with the gap in terms of whether babies that are born thrive, that gap persists over time. So white community overall, because of the variation of more protective factors than risk factors, actually have greater life potential than African American community. Preconception, so focus on preconception wellness, our idea will help to close that gap. So we're starting with, if we can eliminate that, then that alone is one impact that can help close this gap here. Interconception care, so beginning to focus on parenting and engaging with health of babies and moms in this also is looking at closing this gap. We also know by closing this gap that we can actually impact the health of adults. So we see all of our priorities as really contributing to the overall improvement of life potential in closing this disparity between people who are white and people of color. So just wanted to kind of give you a sense of the coherence of why we feel all of the work that we're doing isn't just siloed in those particular bubbles, but is really around this model. Any questions about this? So when we think about focusing on our MAHEC patients, we serve somewhere almost 29,000 patients in Western North Carolina region. 27 of those individuals have identified as being not white. So 63% who are white, 27% who identify as African Americans, as we're beginning to actually track both race and ethnicity together in a way because I think that we see that as the population that we want to make sure that we are supporting effectively. And then some combination of races or other races as well. In addition, we have a pretty complex patient population, so it's hard to see this chart here. But this is birth to mothers with chronic conditions. And so we're taking Medicaid data that's available to us, comparing ourselves to the 500 Cities database. So this is a peer group for Asheville, in terms of the community that we live in, and then state of North Carolina data as well. So if you look, the births to mothers with chronic conditions, this is a 5-year summary, we have a much higher percentage of women with chronic conditions that we serve. So this is a complex patient population that we're trying to impact. In addition, despite that, we're already starting to make some difference in some of those measures around preconception health with the idea of trying to impact infant mortality. Similar kind of thing, same databases being paired to each other. So this is no surprise, we've been able to actually implement the CCWNC maternal risk screening tool, and through that have identified that, again, compared to peer groups in state of North Carolina, we have a significant number of moms giving birth to babies with mental illness. And that should be no surprise, right? We live in a region where behavioral health is a huge impact on overall population health. Again, just trying to give you a sense of the complexity of our patient population that we serve. This is our dream, and there are already communities out there that have built on a history of really tight collaboration that are doing this, which is taking data sources such as claims, payer claims data, EHR data, utilization data through hospitals, so ER visits, skilled nursing facility utilization of specialty visits, primary care visits, hospitalizations, etc., education data, housing data, crime data, employment data, data about foster care and other DSS services, and then community health improvement data. And so bringing that into a warehouse with governance across multiple stakeholders, and I don't know that I apologize if your agency isn't clearly represented here, but everyone in this room would be represented in this governance, with everyone having shared access and kind of web services in order to be able to use that data in an actionable way. And then together, analyzing that data, putting it out in tools where we might be looking at where are we in implementing certain processes of care. What about geo-mapping? Can we identify particular hotspots that we might like to focus in on? And then an overall scorecard of the collective measures of impact that we are taking to have. And so we are beginning to, we're moving forward in baby steps to try to put together something like this just around our MAHEC patients, but really engage us all to be thinking about how can we actually make this happen for our community. So for instance, in Chicago, there's now a multi-stakeholder database that allows for pediatrician offices and schools to get alerts to screen kids for lead because of where they live. In Dallas, there's actually a group of folks at Parkwood Hospital who are putting in place actual alerts that allow an individual who's screened, who has housing insecurity and food insecurity, to be automatically linked to services to help them close that gap. In addition, they have apps that are actually enable individuals with pretty severe mental illness to have spontaneous treatment based on where they access, anywhere in the system where they access. North Carolina, New York City has a similar kind of database that they're working on. There's a lot of communities that were funded by the Robert Wood Johnson Foundation and other partners to take the data that we all have and make it work for our communities and to improve community health. So where are we starting? So this is an example of our initial prototype for our scorecard. So we've got it into our little buckets across the continuum related to infant mortality. We are intending in all cases to look at health equity, social determinants of health, ACEs, and the other environmental, medical, behavioral factors that we know drive change. But all of those items that are listed in red is data that we have access to. Some of it's in our EHR, some of it's through Medicaid. It may not be across all payers. So we're going to start where we've got, what we've got with what we've got, and then improve it as we can. Which one? Immunization.
Okay.
So this is, again, kind of our model. We want to make sure that as we are improving population health, we understand that it's a combination of individual behavior and agency, and I would say also community behavior and agency. There's this piece called clinical community connections. So how can we make sure that individuals, when we are providing with clinical care, we're not forgetting that we're actively engaged with community partners that support them. There's a lot of policy and built social environment work that needs to happen, and then throughout all of this, we're taking the lens of ACEs and the adverse childhood events and equity. So for infant mortality, we are going for the bold, audacious goal that every baby born into and served by MAHEC, and I would say we would like to see that in our community, thrives. And so this is an example of some of the measures that can help us understand whether we're moving in the right direction. Some of the interventions, so we have already sponsored a number of our providers and staff to get training from the Racial Equity Institute, and are looking at bringing the Racial Equity Institute to do trainings internally for MAHEC and community partners. We actually host the ACEs Summit, or are actively involved. We have lots of providers and individuals who are actively involved in the ACEs community locally. And then our research department, which is newly formed, is really working on identifying how can we measure racial bias, how can we measure and kind of health equity, and so we're really working on that. We also are participating with a number of other people in this room in advocating for community health worker and doula funding, and strengthening families and addressing structural racism as a policy and a system level. And a lot of that is being done through community-centered health home. We also are actively through community-centered health home working on integrating doulas and perinatal care community health worker 1 into working with our high-risk population. And that is something that is happening it is underway right now. And then we're partnering with the perinatal home visiting programs and case management programs, as well as through community-centered health home actually working on building community capacity at Piscateview Apartments. So this is, again, just to give you an idea, we have a similar kind of framework for the other priorities that we've talked about. So here's an example of data that we have available to us. This is census tract data that allows us to understand that we've already begun to see that community-centered health home is an amazing model that we want to spread. And if you look at this, this is kind of the population that lives in and around Lee Walker Heights, and their incidence of diabetes is significantly higher than any other of the areas around. And so if we were to think about engaging with a community-centered health home model in an effort to impact diabetes, this would be a community that we might want to approach. So again, this is another way in which we can use data. And then lastly, not talking about opioids today, but talking about the perinatal SUDS work. So our goal is to increase the number of mom-baby dyads in our community. And I think I just want to name that while we all are concerned about babies who are treated with NAS, and we're all concerned about the negative aspects of what's going on in our community, the more we orient around the positive, what we're trying to achieve, that changes the entire framework, and I think particularly in terms of working with women directly. So that's our goal, and we're doing that using our EHR and Medicaid data to us to be able to look at access, the ability to actually have women seen, screened, receive medication-assisted treatment, how much are they receiving integrated behavioral health services or external behavioral health services, and other maternal mortality issues. We are also beginning to look at what we can implement in terms of understanding whether a woman discloses to us. So if we're an organization that a woman feels safe to self-disclose, we're doing something right. So we want to use that as a measure. And then also, are we able to build that agency, self-efficacy of individuals we serve? In terms of, this is all now future. This is our ask, and whether we'll be, whether and when we get it, we'll find out. But babies that are treated with for NAS, neonatal abstinence syndrome, who left the hospital breastfeeding. What about the birth outcomes of the women? What we'd like to do is be able to analyze the impact of Project Cara directly through being able to have patient-level data so we can do that. Counting data, so looking at foster care referrals, other DSS prevention services, and other social determinants of health. And then lastly, case management data, so looking at home visits that we're performing other case management services. All of this to analyze, of course, so that our goal is to know, we think this is going to work, is it working? And if not, can we course correct before 3 years from now? Because most of our data is that old. And then also identifying opportunities that we're not seeing in any other way, so we're developing intervention. So that's sort of our strategy in a nutshell. And I think what we'd love to do is engage you in a discussion. Maggie and Mel and Dan can answer specific questions about the clinical care and the services. But what are your thoughts? What are the strengths of the approach that we're taking? Do you have some concerns? What are we missing? And what can we create together? Also, what are you doing? What can we learn from? So, just curious to know whether there's anyone that'd like to. Yes.
So you mentioned the sharing of data and the collection, and it was impressive the amount of information that you can get. So how have you broken down some of those walls, and what information do you still have?
Yeah, so I would say that we're in the process of engaging with Mission about getting data from Mission. As a Medicaid provider, we have Medicaid data about our patient population. Also, MAHEC has developed a research department division, and through some of the state appropriations money, we're developing a database for research that will support UNC, some of the UNC schools, particularly the pharmacy school. And so we are in the process of engaging Medicaid to get we get the whole Medicaid data set. We have to then specifically ask for permission to use it for some of this public health work as well. But trying to see if we can partner with our research department to be on the heels of some of that. And then we're starting to have conversations with the county about what it is that we can share through the contract we have with the county to help support the community health improvement work. So that, and I know some of the other communities have actually. I haven't really investigated this, but some data should be available just as a Freedom of Information Act, and so that some communities have bypassed needing to sit down at the table with lots of lawyers and go through all of the contracting to just ask for certain data through Freedom of Information. And I haven't actually looked to see what's possible there. We've been pretty good partners so far. Is anyone else aware of some data sharing that's happening in our community that is contributing to our ability to be more agile and effective?
Well, we started to share data with Mission Health Partners around the uninsured, but that's really at the patient level. It's not that, Jackie. I know. I mean, we were going to be using the platform, and they're doing population health as well. But that kind of seems to have fizzled out, so. I think we've had conversations like this in the past about sharing data. This particular issue has always been challenging because of different systems and data being warehoused in different ways in different organizations.
Yeah, I think that there are technical solutions to the differences across data. The biggest barrier has to do with being willing to share it. And so I'm just, and if you look at other communities, so the Camden Coalition is an example of a community that's done a lot of work in data sharing, has, had to take it incrementally, but a lot of it has been being able to navigate through the concerns across organizations about things like HIPAA and privacy and even a little bit of power sharing. Like, data feels like power. So you've got my data, does that disadvantage me in some way? Not to say that that's necessarily where we're all coming from, but it's also human, right? But there's an example. Camden Coalition is really out and ahead in terms of their ability to manage, really support communities around complex care, and they're leading the nation in approaches that are making a huge difference. I mean, they were one of the first to use hotspotting, a lot of you know, it was almost a decade ago. And it just strikes us that we have this community that's been collaborating for such a long time. Is their interest in us coming together and trying to, again, to engage at a different level, sharing data.
Well, I think it depends on what type of data it is. I feel like we do have to give ourselves credit. Even the substance abuse group that we had that meets yesterday, only, 2 or 3 years we've been meeting, and there's huge amounts of data that are shared. I mean, even the new report coming out that Mary Ellen was talking about with research, the babies that, what drugs they were on and all that stuff. So I just think it depends what type of data you're talking about, but I feel like overall we have sharing agreements and specific, it's just there's always different departments that sometimes have difficulty in sharing. So I think, I feel like overall in our community we do a good job with that. It just depends sometimes on, if you're talking about patient specific, if we have to get releases or not, all the way down to macro data. But it's just sometimes just figuring out the puzzle of it.
Yeah.
So one of our ideas in presenting this is that MAHEC is going to do this internally. I mean, so we have 30,000 patients. And what we think is that if we can actually create a dashboard that looks at a life course model around preconception health, well, we're starting to track measures amongst those 30,000 patients, where we have preconception health measures, where we have prenatal measures, we have birth outcome measures, we have interconception care measures, and we can create that dashboard. The data that we have internally, we have a lot of that. And if we can build it and start to track it, using Medicaid data, using Mission for birth outcomes data, a lot of that then is that we can help to drive at least improvements on the 30,000 patients that we serve. And the question is, will that then influence the broader community? How can we leverage what we can do internally with what we can do externally?
I think the question then is, what, in terms of the dashboard you develop, does it become freely accessible, or are there costs associated with getting licensure to access it? Is it, double documenting for people who are doing on the ground work? Or is there a way for systems to crosswalk and talk together without extensive technological build out? These are the things that we're seeing from the state HIE level all the way down to our, departments even conversing. So this has been a kind of a holy grail since I've been sitting in this meeting for years, and I think it's we have to continue to have the discussion. If we succeed with this around infant mortality, You know, then will we have a whole separate system for, you know, opioids and substance use outcomes? Will we have a whole nother system around diabetes and that kind of prevention? And the only other thing that I'll say is that, and I'm certainly not trying to be a naysayer around it. I definitely try to think innovatively about this often, and I know our whole organization does. But I also have curiosity about the chip and the CHA process and the Winchon dashboard and what can be used there. I'm not as familiar with it here in Buncombe County, but a project that that I'm working with in McDowell County has signed on at minimal or no cost to put our small programs, performance measures towards the community health assessment plan that they're compiling and reporting there. So knowing that hospitals and health departments have to do that seems to me like a really good place to start to say, okay, you guys are going to be doing this anyway through community health work. What is the ways of least barriers to get us to a system where it's housed that we can report out at the macro level?
Yeah. And I know that, you know, those are some of the details that we need to be, are to be thinking through is how can we have this feed into Buncombe County's CHIP scorecard, you know, so that there are different end users for the data and how can we make it available. I think that one of the things that we've come to understand is the CHIP and CHA data oftentimes is already 2 or 3 years old. So can we actually start moving towards, you know, so building off of that, but can then we start branching out towards having, you know, available data that allow us to know what's changing in 3 months or what's changing in 6 months so that we can be a little bit more agile. And I think that the idea of having a different database or a different system for each priority, I think it results in more siloing, right? And so it's coming together to have the right experts looking at the data, being able to analyze, to help us identify where there are opportunities we have predictions about what's going to work, but can we really demonstrate that what we're doing is making a difference? I think that I've been in quality improvement for a decade. I've been MAPEC, you know, I would just be the first to stand up and say that I don't know that we've always been as true to being able to say, yeah, everything that we're doing is making a difference. And so, you know, how can we bring that transparency, that level of transparency, and even humility to being able to use data effectively.
And I can just speak a little bit to the community health assessment and improvement process. So I think that's been historically somewhat of a barrier and a challenge as you work through the data that you do have available to you, and you recognize that there are issues that are rising to the top. And wouldn't it be great if in that process you could say, well, here's the data that's 2 or 3 years old, here's the trends we're seeing, but oh, here's a whole other pool of data that we own as a community that feeds into that and really sharpens that view of how we address those issues. And to speak to what you're saying, I think that starting with priorities that we're in a mid-cycle with right now could very well be a great way to prototype the true, honest, and authentic sharing of data, which has so many barriers to it. So I really feel like if we could, and you know, forward thinking, looking at it as opposed to here are the issues we're seeing, more broadly about here's what all the data is telling us, and then looking to see where it all cross sectors or comes together at certain points. But it's really about what's happening in our community that is timely and that we can evaluate now instead of looking to see where trends have gone and where we're going, but we're always 2 or 3 years behind that.
And when we think about the social determinants of health, the idea that there's a wealth of data that the county has that has a huge potential for helping us understand what we could be impacting that may not even seem directly related to the care, the condition that we're trying to impact, if that makes sense. So.
Can I ask a question, Dan?
So just looking, going back to that chart where you had all your, like a prototype for infant mortality. So, like under preconception, is the thought that, because I'm trying to remember, but it's, if I remember those measures, it was to look at one individual and all of those things, right?
Yeah.
And that would tell you like her wellness,
Yep.
correct? So, I'm just trying to wrap my head around this, right? Would that be the case for all of those different? Like you gather all that data for one individual and it would be linked to that one individual? And then you could somehow,
That's the goal, right? I mean, so if we are trying to understand what kind of care are we providing? What kind of health care is MAHEC providing to the patients it serves, right? So these are all kind of points in time. And in order to understand how we need to improve, the ultimate goal is the birth outcomes and then beyond, right? So each part of this time frame will affect that outcome. So if we only focus on preconception wellness and everything in prenatally goes wrong or their birth experience goes wrong, then we didn't change anything. If we only focus on their birth experience in the hospital and forget about their preconception wellness of what they're coming in on, then we're not going to get the outcomes because that's the way we've always done it, right? And so you're exactly right. In order to design the programs to achieve the goals that we want, we're going to have to do it over time and actually link the results to the outcomes to the risk factors, is so that we know whether our programs are working. I mean, we got programs out the wazoo that are doing stuff, right? I mean, we're doing stuff. And the question is what we're doing working? And I don't think we actually know. Each one of us has a great program that is getting great results. And yet, we have one of the worst disparity gaps in the state. Our preterm birth is rising. And so each one of us thinks that our program is doing what it should do, and yet our results as a community is not getting what we want.
Yeah.
And so we're going to have to deep dive and figure it out differently and say, how do we know what we're doing is going to work? And so this is the idea. It's huge, right? I mean, this is massive. But I think this is what it's going to take. And the good news is that in looking at our data, just internally, everything in red there is capturable today. We just got to start reporting upon it and looking at it, right? Everything in red on there, we've gone through our system and said, we can get that. We can get that. Like actionable right now data.
And to add to that concreteness, the work group or the task force that's for the whole organization across all the clinical sites can have data presented to them in a way to make sure, are our clinics delivering the care they should be? And that's one intervention, is to work with clinics. But then also through a regression analysis, what of it that's happening is actually making an impact. And so that kind of both and, if that makes sense.
This dashboard should drive our programs, right? I mean, that's the thing, is that, but again, we don't even know what it's going to look like. But once we have it, if we start reporting this kind of level data for our MAHEC patients, we're going to start to see, oh my gosh, we're doing really well here, but we are really, this one is not making any difference. And we're going to say, why? What are the partnerships? What are the programs? What are the things we're missing? Why is this not doing what we think it should be doing?
but just maybe think if all that is, like, if it's patient A, and you're collecting all that data, and yet, like, how you, if you're trying to get data from other agencies, like, how it becomes, you know what I mean? That makes sense.
So the data from other agencies is a bigger piece.
Right.
So think about this as a MAHEC dashboard.
Right. That I know.
But think about this now on a community level. If this is not just a MAHEC dashboard, what would that look like? So first we got to figure out if this is going to work internally. But if it does, and we can say, okay, MAHEC can reduce MAHEC's infant mortality. MAHEC can reduce MAHEC's gap. Then I think we have something.
And do you think that with, I mean, knowing that we do have a disparity, we always talk about the low numbers, right?
And so it's hard to see.
Yeah.
In that case,
That's where it gets, like, you need more, the end.
Well,
needs to be
which is
bigger.
I mean, that's a really good point. So if we only have 17 deaths out of, 4,000 or 5,000 deliveries, and that varies, you can vary year to year, and how do you know what's going on there? But that's why you have to have a ton of different measures, because it's not just the infant mortality per se, it's the preterm birth rate, it's the, the NAS rate, it's the dyad rate, it's the foster care rate, it's all those other things that are probably more important for our community than just the infant mortality rate.
And they're like
Right.
proxies for health, yeah.
Then you take the complexity of somebody who has Medicaid for pregnancy, but it doesn't have the Medicaid prior or after 2 years, and how do you connect all those dots?
And that's
Yes.
why we're going to start where we are. I think that's part of this journey, is being willing to just jump in where we are and be true to ask, being clear about what the data really says and doesn't say, but not waiting, and then understanding what it is that we want to ask for more of to help us fill in those gaps. But I think that's a big part of the learning from all these other communities, is they just started. Does that make sense? Like, it does, it impacts the accuracy of, you can't say certain things if you don't have the longevity, but.
Any discussion during this mapping around the impact of alcohol in preconception and beyond? Education for the mom. I know you have the 3 months of folic acid.
Yeah.
And wondering if that is a factor. I know you also mentioned tobacco and other medications that could be harmful, but what about alcohol?
Yeah, it's great. I get that question almost every time I speak about preconception wellness measures. And the reason is, alcohol is absolutely important. There are 25 preconception measures, like alcohol, that are possible to look at and all important and all impact outcomes. Alcohol is harder to measure. Right now in our EHR, we're routinely capturing tobacco use. We're routinely capturing some of these other ones. We're not routinely capturing alcohol. And so there's this balance between what you can measure and what is important. And so we could list this list actually could go on for another 15 on that category. But we have to start somewhere. And so the reason why we stop at 11 is because the first 9 are ones that we can actually measure right now. And there's a thought, and this is the thought around the preconception wellness measures that I've talked about, is that if you have those 9 in a positive, healthy category, they're a proxy for many of the other things that we're not measuring. There is some manner of wellness that once you have enough wellness, you probably have a lot of wellness. Versus if you have a few, you probably have a lot of other things that are not well as well. Yes, so using it as a little bit of a proxy to measure is the theory behind that. Does that make sense?
Yeah, I still want it in there.
Put it in there. Put it in there.
I don't like your answers.
Fair enough. That is absolutely okay.
Good.
So have there been analyses of the data yet? Or is this, not this available?
Not yet.
Okay.
Coming.
It's coming soon.
Soon.
I mean, that would be really fascinating.
Yeah.
to see
Yeah.
what
We're
you've
waiting.
got and what you can do, and I think that will help with the discussion.
Yeah.
I feel like, this is kind of an iterative thing where we're gonna see what you're able to produce
Yeah.
and then see where there are missing pieces, and then we can discuss that. It's kind of a huge concept right
Yeah.
now that's vague.
Right.
So, I think everyone would be amenable, but, it's hard to talk about specific contributions until you see where you're starting, and what's possible.
I think that's a really good point.
That
And,
is.
and that's what this is presenting, this is basically presenting the idea
Yeah.
and getting some feedback
Yeah.
and saying, what do you think?
Yeah.
And, the next step is to actually do it
It'd be great to see.
and see what the data says.
And come back and share.
And then you can ask for alcohol at the end of that. And they can't find the reason why there's.
And I would add that this and this, like, so the fact that we want to make sure that we've got measurement in each of these circles.
Yeah.
And infant mortality is the main,
Oops, sorry.
is there maternal mortality work maybe in the future too, or just focus on infant mortality because that's all we're pressing this year?
Well, remember, we're actually focused on looking at those three things based on the CHIP priorities, right? Do you want to speak to maternal?
Well, I think, if I can, two things. I think one, just kind of grounding this back down into the clinical work, of which is the heart of what we're all talking about, is for those who have worked on the perinatal substance use team, like, think about how many times over the last 3 years we have said, hey, here's an opportunity for increased clinical capacity. However, you know what they want? They want to know what these numbers are. Like, I am 100% confident that if there's a way Tammy Shook and Project Cara and the OB care managers and Mary Ellen could have had a way that we could have our data that connected in some way, right? I mean, I think the potential to even find out what other capacities we have, because we've not been, and there's not been a format for us to collaborate truly with data, right? Really, our data sharing looks like, I took care of about 200 patients this year so far. How many have you taken care of, right? But there's no formal way of which we share data and are able to collaborate. So number one, I just want to speak up for our patients who aren't in this room that says, oh my gosh, if you guys could get together, this might make some movement, number one. And two, when we look at the maternal data, know that we sat through for the substance use piece in particular and looked at the aims that start with mom. And I know Dan's going to probably laugh at me when I say this. So in my head, when we look at these categories, I have to dumb them down and just say health, right? Because it's the continuum of, who I was when my ovaries turned on, and then whether or not I decided to use them or not, and then when they stop working, right? Like, that is the continuum of a woman. And so I don't think that, that's how I have to put it in my head, because I think sometimes we get so stuck on the terminology of which that framework has changed the ability to speak about women's health, right? But I think if we bring it back down to women's health, you can't look at the baby without maternal health, and we're really just saying women's health.
Well, that's right. Like infant mortality with me, yeah, it's sort of like diet. You know what I mean? Again,
It's all right.
Right. I think the other piece of, again, speaking to these other communities, one of the reasons they've been so successful, they've had multi-sector agreement to focus together. So it's hard because everybody has their passion and the thing that they want to see get improved. I'm not saying that we shouldn't work on multiple things at once per se. But the learning and the system capacity that we could build, if we all came together and said, okay, we're going to make an impact on infant mortality, knowing that what we're putting in place is going to then impact everything else.
What we're focusing on, just to be clear, again, is we want to close the gap. Our numbers are small, but we should be able to close that gap. That's what we want. There shouldn't be a gap.
I think it's commendable that you guys are rolling this out in a way where you're looking internally, your systems, your data, come up with a model that may be replicable to bring other agencies in. I think that's a good way to do it. Imagine talking to this group if you said, I want your data, your data, your data. We've done that before. And everybody says can't do it, including us. But
we tried.
I like the fact that you're trying to get this thing perfected internally and work a lot of the glitches out, and then come back to the community to say, what can we do? How can we work with it? I commend you guys.
That's really validating. Thank you. So one of the theories behind that is that we believe that Mayheck has a representative population of Buncombe County. We have actually potentially a sicker population, not as sick as Winches and Blue Ridge, you know. But so we might be a representative sample of both insured and Medicaid patients that we serve. And so if we can do this, then we can do it bigger as a community.
Well, in your role as the, safety net hub for regionally, I mean, you're seeing some of the sickest patients from all of our western counties.
Right.
So that's.
And we are linked to Winches
Yes.
because we deliver their babies, right? And so, and those are gonna be in this dashboard. Those are birth outcomes, and they're gonna show up.
And I think what it's important to know is that different entities are also regulated, like by the federal government. You have the UDS data, which is very detailed. And nationally, it's the most comprehensive health data you can find.
Right.
So to give credit to that, it is behind, it's usually 2 years delayed, I think. So I think the real-time stuff will definitely help, but I think having the infrastructure to have someone to do this data full-time is going to be important, because it's going to be critical to develop the dashboard, but you're going to have to pull from, because we're federally regulated. We have 7 different systems, just that mission. So that's why it's so hard, because you have all these vendors, and then you have federal regulation. We have to be held accountable from infant all the way to geriatric. So that's why it's very comprehensive. Like when I listen to it, I'm just like, oh gosh, there's so much to do in that. But if there was a full-time team doing that all the time, it's realistic. But you just have to make sure that's in your infrastructure and budget.
I always start small but think big. So the Camden Coalition has been around for over a decade. They actually pay entities for their data. They have existing agreements with school systems and healthcare providers and the counties, police departments. They pay people for their data, and they also make it accessible. Everybody has access to it. And so they established a separate nonprofit because they realized in order to do that, that's what had to happen in order to step outside of all the political boundaries that are in our way. So, and I'm just going to name that MAHEC is intent on sharing power in this. We really want, and we know that everybody else in this room, like us, wants to be reminded that it's about the outcomes. But I think it requires all of us to be willing to think that way. And so we're not asking for your data now, but we will be. And it may not be us. Maybe we decide that it needs to be some other entity that does it. But
I wanted to add one other piece about the data. So most of us know that really the key driver of the disparity in infant mortality is structural racism and the way that our system is set up to work against people of color. And so we know that there's interventions that are particularly working on those different barriers that people have to care. And so one of the other things that we're working on doing through our research department and a health equity audit is to be able to pull data from patients that are getting touched. For instance, I know some of you have heard about the doulas that are working, that are hired from public housing, so who the doulas are touching, seeing those types of things, being able to see who's getting touched by Pisca Legal, like all of those different things. Like our research department is also really focused on figuring out how to pull data in a unique way. And so that is a lens that, like, for me, I'm always going to stress is that is the main driver of the disparity in infant mortality is the access and the racism. So being able to see those pieces and being able to evaluate and research and measure that is also something that we're very intent and focused on.
So we have about 3 minutes left in our time, which I'm sure we're all happy to have some continued discussion, but in the interest of everyone's time, I do want to end on time. So any last question or comment about our topic today? The one thing that I would add is that we're talking about infrastructure, and we're seeing to your point about evaluation of the data and having that as part of this model. The partnership that we have between MAHEC and the county around the community health assessment process, I think, is a real foundational piece of how this is all kind of coming together in the way that it is right now, because that is one of the components of it. So yes, it would be, as we look at, could this be replicated, in our other practices across our community, that is an important piece. So we want to continue to have that dialogue on how the community health improvement process can help support that going forward too, as we look more about data sharing and social determinants of health. Any other comments? Okay, if you have not signed the attendance sheet, please do so. And I do have parking passes for everyone. And please, you're welcome to stay and continue the discussion that you would like to. Thank you all for being here.